Clinical case, Streptococcal shock syndrome in a 10-year-old child. Note: this case study is fictional and is provided for illustrative purposes only. Real-life cases may vary in presentation, management, and outcome. Patient information. Name, Michael. Age, 10 years old. Gender, male. Medical history, no known underlying medical conditions. Michael is brought to the emergency room, ER, by his parents with a sudden onset of severe illness. They report that he woke up this morning feeling unwell, with a high fever, chills, and body aches. Over the course of the day, his condition deteriorated rapidly, and he became increasingly weak, pale, and confused. Initial assessment. Upon arrival at the ER, Michael appears pale, lethargic, and extremely unwell. His vital signs show a heart rate of 160 beats per minute, blood pressure of 80/40ths of a millimeter of mercury, respiratory rate of 30 breaths per minute, and temperature of 39.5 degrees Celsius. He is shivering and has cold extremities. Examination of the left leg revealed extensive swelling, induration and edema with dusky skin, blistering and bleb formation, in addition to an area of gangrenous skin. "10 days prior to admission he had a cat scratch to his left leg and the parents did not seek medical advice at that time. Fluid resuscitation. Michael is immediately started on intravenous fluids, including normal saline, to stabilize his blood pressure and address fluid deficits, antibacterial therapy. Diagnostic workup. The medical team in the ER promptly initiates a series of assessments and tests to determine the cause of Michael's severe illness. Blood tests. A complete blood count reveals a markedly elevated white blood cell count, indicating an ongoing infection. Blood cultures are obtained to identify the causative organism. Creatinine and BUN were greater than the upper limit. Platelets was decreased. Prolonged PT and PTT, low fibrinogen level and high level of D-dimer. Elevated ALT and AST. Total bilirubin was normal. Imaging. A chest X-ray is performed to evaluate for any signs of pneumonia or other pulmonary complications. Surgical debridement of all necrotic tissues and drainage of involved fascia planes were done for our patient after stabilization of his vital signs and improvement of his general condition. Blood cultures grew Group A Streptococcus, as did wound swab culture. The child showed great improvements in his clinical condition after the 4nd day of antibiotics and supportive treatment. The wound healed normally and antibiotics were administered for 24 days. Questions. What is the most common cause of toxic shock syndrome? Most cases of toxic shock syndrome are caused by a toxin produced by Staphylococcus aureus and Streptococcus pyogenes, group A strep infection. Clostridium sordelii can also cause toxic shock syndrome, but it's less common. Does group B strep cause toxic shock syndrome?
Streptococcal toxic shock syndrome was historically associated with group A streptococci. However, increasing evidence was found that other streptococci including groups B, C, or G can cause toxic shock-like syndrome.
What is the bacteriological criteria for definition strep toxic shock syndrome? Case classification. Probable. A case that meets the clinical case definition in the absence of another identified etiology for the illness, and with isolation of group A streptococcus from a non-sterile site.
Confirmed. A case that meets the clinical case definition and with isolation of group A streptococcus from a normally sterile site, e.g., blood or cerebrospinal fluid or, less commonly, joint, pleural, or pericardial fluid.
Why penicillin is less effective in children with streptococcal toxic shock syndrome? Penicillin, though efficacious in mild Streptococcus pyogenes infection, is less effective in severe infections because of its short post-antibiotic effect, inoculum effect, and reduced activity against stationary phase organisms, Eagle effect. Emerging treatments for strep TSS include clindamycin and intravenous gamma globulin. What is the mortality rate of streptococcal toxic shock syndrome in children? Despite aggressive treatment, the mortality rate for STSS ranges from 30% to 70%. Mortality from STSS is substantially lower in children than adults. Prognosis of streptococcal toxic shock syndrome is worse than staphylococcal toxic shock syndrome.